Okay, everybody, if you want to go ahead and take your seats and get settled, we're going to go ahead and get started here momentarily because we have a lot of good content and a packed agenda this morning. So we want to make sure that we have time for everything to work through here today. As you see up on the agenda, this is kind of our roadmap for the morning that'll take us all the way through till closing at 12:30 this afternoon. We're going to start things off this morning with an overview of liver disease. At the midpoint, we're going to bring up one of our pharmacists, and we're going to dive in a little bit deeper in terms of medication. And then we actually have a kind of a day in the life of a hepatology nurse in that perspective, which I think you're going to find very, very interesting here today. So you're going to get a lot of different disciplinary views of liver disease as we go through here. Lots of opportunities to ask questions. So as we go through the wheel of our different components of the class here today, this will give you an idea what we're going to focus on in the different increments as we move through. We're going to start off with pathophysiology. We're going to move into diagnosis, and then we'll be covering medication components, case studies, and nursing interventions. Because this is essentially an education course, these are the main learning objectives that we're going to try to cover for you here today. So this is what you'll be able to take back to your clinics and socialize with your peers. We're going to be looking at the causes of chronic liver disease. We're going to try to get a better understanding of the laboratory abnormalities that manifest in chronic liver disease and understand some of the methods of diagnosis for cirrhosis and some of the complications that lend themselves to that. So I think you're going to come away with a lot of good information here today. And I think it's kind of funny. You know, I'm kind of a pop culture person sometimes, and you know, the liver seems to get used in a lot of comedy, a lot of punchlines all the time. Do you find yourself recognizing that? People will say, like, sometimes I drink water just to surprise my liver. Or Friday is the beginning of my liver's work week. You hear a lot of jokes on TV about the liver. But the truth is, it's one of the most critically important organs of the human body. It does everything from processing nutrients to removing toxins from the body. It takes it on the chin a lot and doesn't always get the incredible amount of respect it deserves. So we're going to give center stage to the liver here today and learn more about it so it gets elevated in that pantheon of human organs. To begin with, we're going to start off with Dr. Atif Zaman. Dr. Atif Zaman is a professor of medicine and clinical vice chair of medicine and section chief of gastroenterology and hepatology at OHSU. His research interests are hepatitis C, portal hypertension, gastrointestinal bleeding, public health, and liver disease. He received his medical degree from Tufts University, did his residency at Baylor School of Medicine, and his gastroenterology fellowship at OHSU. He's a frequent lecturer and author of more than 50 manuscripts, review articles, and abstracts. He's also the recipient of the Western American Federation of Medical Research Outstanding Investigator Award. Please join me in welcoming Dr. Atif Zaman.
Thanks.
Welcome.
Thank you. So, first wanted to say it's always very embarrassing. I hate sending off bio sketches because you're actually standing there and someone is talking about you, which is very uncomfortable. So I wanted to really spend time today not putting up slides. I had a chance to look over your syllabus, and there's plenty of slides that you have, not from me, but a lot of things that I will talk about that'll be great review. And what I wanted to do today, and I hope you are okay with it, this is kind of the way I work with a lot of our trainees and our fellows. And what I try to really emphasize is not to try to memorize things, because what's going to happen is when you're in the heat of battle taking care of patients, you're not going to be able to run to your notes and go, wait a minute, what was this or what was that I had to worry about? What I really want to focus on today is conceptual things, all right? So when I talk about conceptual things, I should be able to not have slides that I drone on, but actually use a chalkboard or ask questions, and we work through things conceptually, all right? Because there are patterns that what your body does and how it responds to injury that really you can take across every type of organ that you can think of, and the injuries and responses are usually the same, all right? And this is actually the way medical school training is now changed to, which is kind of really emphasizing foundational principles and then building upon it, all right? So I'm gonna try to do that. It'll be hopefully a positive experiment with you. And I don't know, has anybody actually done any kind of lectures like this where there's no slides and just a board? Great, there's like one brave person, and she kind of shook her head and said, I was the worst ever. No, I'm just kidding. So that's what I'm gonna try to do, okay? And then we'll have some time for you to add questions, because everything I'm gonna tell you, it's gonna generate some questions. So hopefully you will write down notes feverishly, and I'll pause at places and repeat things a few times, and that usually is your key to remember this must be something important, all right? So and med students, that's my code word to them, that's probably what's gonna be on the test, okay? So there's no testing here, but that's a code word for them. So what I wanted to first start off with is asking somebody here, does anybody know what cirrhosis actually is? We use these terms, and I'm going to ignore Karista in the back there because she's not supposed to answer any questions. Because it's like a lot of words we use, like organic and sustainable. You see it so often. When someone ever asks you, like a patient, what does cirrhosis really mean? There's a pause. I kind of know, but I don't know. And this is really interactive. I promise I will never call on anybody. But if anybody wants to answer, and my technique always is, there is never a wrong answer. Things are closer to being right, and that's what we'll do. So don't ever feel embarrassed if you think it's wrong. So cirrhosis.
Cirrhosis, from my understanding, is echographically appears, the liver echographically appears nodular. There's severe fibrosis that creates silos of hepatocytes that are functional and newly forming hepatocytes as well. But they then are kind of individualized, and the organ does not function the way it should.
Great answer. So what was described right here is a histologic, meaning if you did a liver biopsy and looked at it under the microscope, plus radiographically a view of cirrhosis, which means what happens is if you did a liver biopsy and looked at cirrhosis, what you would see is actually islands of normal tissue of regeneration that's happening. That's why they sometimes say regenerative nodules. And then when you look at it visually, it's a nodular appearing liver. So the surface looks nodular because your liver is trying to react and regenerate. But what happens is then you also get these bands of scar tissue around these areas of regeneration. So you get that kind of depressed nodular look to it, and the liver can shrink, all right? But in essence, what it is the end damage or end stage of chronic liver disease. I mean, if you verbally had to tell a patient what cirrhosis is, you could use very, terminologies like histologically and radiographically is what you see, but the patient's just gonna totally blank on that. What it really is chronic liver disease that ends up with end-stage liver disease, or what I always tell patients is a lot of scarring of the liver. And what I highlight to the patient is you have so much scar tissue or scar cells replacing regular functioning liver cells that at one point your liver may start not functioning and doing what it needs to do, all right? Now that is a tipping point. So the other term, which is now in the last 5 years at the highest level of liver research and liver understanding, that's where we've come to, is where you now have clinically someone who has compensated cirrhosis or decompensated cirrhosis. So of all the century plus of research in liver disease, we've come full circle back to a very simple concept. You can have cirrhosis and it can function fine until it doesn't. So you go from compensated to decompensated, okay? So that's something that we will then really expand upon, because the first question you'd want to ask is, well, what are the events of decompensation? So I'll ask that in a minute. So I mentioned to you chronic liver disease, and then eventually with ongoing damage, you go on to cirrhosis. So any thoughts on what are causes of chronic liver disease? And I just want to let you know, from my experience, when you tell a patient that they have cirrhosis, the first thing they say is, hey, you know, I don't drink alcohol. Okay? So that's your hint. So can someone tell me what is a cause of chronic liver disease? It's hepatitis, Hep C, and I'll give a hint already, alcohol. So if you look at, depending on what literature you look at, alcohol is either number 1 or number 2 cause of liver disease. Please don't forget this. So we can, and it happens all the time, everyone focused, wow, I diagnosed hepatitis C, and then forgets to work with the patient on the alcohol use, right? So I've had patients refer to me, please eval for chronic hepatitis C, and then I find out that the patient is drinking a case of beer a day. And no one talked to them, because we get really obsessed about a quote, treatable cause of liver disease and forget that alcohol and alcoholism is potentially something we need to work on and help with treatment of ongoing damage and the chronic liver disease. So alcohol plays a huge role in our society, a massive role in our society. So I would argue that we should always force ourselves to think about somebody has chronic liver disease, let's find out about what their alcohol history is. So as I say this, does anybody know how much alcohol is too much alcohol? And what is considered safe amount of alcohol? Anybody have an idea? Yes?
14 alcohol equivalents per week for men and half that for women.
Yeah, so you've read studies about that, right? So can anyone tell me what that literature is based on? So can you imagine, has anyone done a study where they've taken 100 people, taken half of them and say, you will not drink for 10 years, and the other half, I will force drink you for the next 10 years at different levels, and let's see what happens.
You have a lot of volunteers.
What's that?
You probably have a lot of volunteers.
Yeah, you would. Yeah, right. But would they stick with it? That's the thing. My point is that the science behind it is really vague. It's based on a lot of epi data and a lot of indirect data, and it's really hard to know exactly how much is really safe for a person. Most of those studies, of course, did not take into account, and as I always tell my patients, there is no divine or constitutional law that says you're allowed to have only one chronic liver disease. So you could have alcohol as a source of chronic liver disease and hepatitis C. That was the other thing that was mentioned. So when you take two things working on the liver, 1 + 1 does not equal 2. It's quite synergistic, and it's probably 1 + 1 = 25 in terms of how rapidly the damage occurs here. So always make sure that it's critical to think about alcohol and how much does the person drink. The literature does say exactly what you had pointed out, that 14 drinks for men, half of that for women over a week's period or so. A lot of that is based on another common cause of chronic liver disease, and we're going to leave hepatitis C out of this. Does anybody know the sister or brother or family of alcohol-related liver disease, the flip side? NASH, exactly. Non-alcoholic fatty liver disease, okay? So when someone has fatty liver disease, you always have to ask the question, is it alcohol-related or is it non-alcohol-related? And as you can imagine, it can be a mixed picture as well, right? Someone can drink almost worrisome amount of alcohol, but also have all the risk factors for non-alcoholic fatty liver disease. Does anybody recall what are some of the risk factors for non-alcoholic fatty liver disease? Just want to let you know, one of the causes is within the title of non-alcoholic fatty liver disease. Yeah, being overweight, right. It's not fat, or it's overweight, it's not morbid obesity. So someone being overweight. Other risk factors, these are very common things that occur in the US population, actually worldwide. Diabetes, high blood pressure, and cholesterol problems, all right? So those are the four key variables. And you can imagine a lot of the US population have those variables. But remember, you can have fatty liver disease of the alcoholic type and the non-alcoholic type, okay? For alcohol-related, stopping alcohol is the treatment. For non-alcoholic fatty liver disease, it's a lot more complicated. The mantra is the following: weight loss. And there's actually been studies that show that if you lose about 20 pounds per year, the first year you'll start seeing liver tests normalize, and on imaging studies you'll start seeing the fat resolve on imaging and on liver biopsy. So weight loss plays a critical role, as well as controlling diabetes. Diabetes is a huge cofactor in fatty liver disease, and controlling hypertension, hyperlipidemia. As nurses, you must get this call many times from a patient, you know, my liver tests are elevated and my cardiologist put me on a statin. Is statin safe or not, okay? And the answer is statins are perfectly safe in people with chronic liver disease. Actually, for fatty liver disease, it may actually lower the liver enzymes, okay? So in general, it is safe and should not be avoided in people with elevated liver tests in general, okay? So hepatitis C, as you know, we have cures for hepatitis C. We've had cures for hepatitis C since 1992, but back then our cure rates was about 5%, and we used interferon. Then with interferon, adding ribavirin, and then one of the new oral agents, direct antivirals, telaprevir and boceprevir, we got it up to 80%. And now interferon-free regimens are close to 100%. And you're going to hear a talk a little bit later kind of going over the hepatitis C landscape and treatment options there. But there is a cure for it. And another common question patients ask is, am I truly cured, or am I in remission and have to worry about it? This is not like hepatitis B or HIV. Once you clear the virus, it's a cure. And they have 15, 20-year follow-up studies that show that it's a permanently gone, long as you don't reinfect yourself. So that's the other thing. Just because you have the Hep C antibody and you clear the virus, you can always get reinfected. That antibody is ineffective in actually combating hepatitis C, right? Because you're antibody positive and you have chronic infection. So reinfecting, that antibody is going to be ineffective, okay? There's also hepatitis B Pop Quiz. Which is the most common chronic viral infection worldwide? I just gave you the answer. B. It's B, right? In this country, we obsess about hepatitis C, but worldwide, it is hepatitis B. Worldwide, liver cancer is number 3, I think, in terms of cancers that occur worldwide. The number 1 reason for that is hepatitis B. It is a class 1 carcinogen defined by the World Health Organization, all right? So hepatitis B, which we will not talk about, is something that is quite common worldwide. One thing to remember is if you have somebody come from other parts of the world, developing countries, you always want to check for hepatitis B, whether or not they are symptomatic, whether or not their liver tests are abnormal, because liver tests can go up and down, and a snapshot may not be good enough, okay? So for Hep B, if they come from a developing country, it's always good to check and try to exclude hepatitis B. Any other chronic liver disease you want to throw out there? This is chronic, not acute. So no one should say Tylenol. That's another common thing that patients always bring up is, you know, I've been taking Tylenol for years. Do you think that caused my cirrhosis? Most medications do not cause cirrhosis. There are a few. Does anybody know of any? So one that is relatively common that's used is methotrexate. Methotrexate can cause fatty liver, NASH that leads to cirrhosis. There's a few other ones that's not used commonly, but one of the most commonly used, I wouldn't call it a medication, but a commonly used supplement by patients that may not realize can cause cirrhosis is vitamin A. So if you take over 10,000 units, I think it's in units, of vitamin A a day, it can cause cirrhosis. So something as what you would think on surface is benign, vitamin A can actually it's well known to cause cirrhosis at high doses. Yes?
What about occupational injury? Like people, we have OSHA now that, around the world, we used to work with benzenes. And
Yeah. That's a great question. This is around how about occupational exposures to chemicals. There definitely, of course, are chemicals that can cause fibrosis. They're poorly studied because the problem is that how much exposure do you actually need to get it? And with OSHA guidelines on protection, intermittent exposure should not cause cirrhosis. Now, if you've been working and swimming around in chemicals, I mean, I can't kind of comment on that, but we'll get sometimes patients come to see us who have cirrhosis and they've worked in chemical factories. But in general, if you follow normal guidelines, even if you have intermittent exposure to chemicals, that should not cause cirrhosis. Because remember, cirrhosis develops after chronic long-term injury. What I haven't mentioned is when you reach cirrhosis, it doesn't happen typically over a year or two, it happens over decades. So you would have to require exposure, continual exposure over decades to develop cirrhosis from chemical exposure. Okay, great question. Yes?
Is polycystic kidneys totally different?
It's completely different. Although, if you start replacing your liver with more and more cysts, over time you have more cystic lesions than liver cells, so you can develop liver failure from that. And we do transplants in those patients, but a totally different mechanism. Not fibrosis cells replacing hepatocytes, but actually cysts causing more compression and leading to almost mimicking what cirrhosis does in terms of complications.
So the cyst is kind of like the scar tissue.
Yeah, and it's really literally compressing, but it's impressive to see that someone with polycystic liver disease, you can just basically see all cysts in the liver, but still have a perfectly functioning liver. Because, it's compressing, but how much before the damage starts happening, no one really knows, okay? So we've talked about some of the very common causes of chronic liver disease. Some of the rare causes are autoimmune disease, right? So you can look at autoimmune diseases that lead to chronic liver injury in a couple of buckets. One is your immune system attacking your liver cells, and that's called autoimmune hepatitis. Makes sense, right? Your immune system attacking the small bile ducts in your liver, and that's called primary biliary cholangitis. And you can have your immune system attacking the large bile ducts in your liver, and that's called primary sclerosing cholangitis. So you can see it's whatever level your immune system is attacking what structures in your liver, you define autoimmune disease. And there are different treatments, some have good treatments, some don't, but that's just another bucket. I don't expect, and you shouldn't expect to know exactly what are the autoimmune diseases, but you can, but just remember there's autoimmune liver disease as well, and it's based on what structure it's attacking, okay? You can actually have iron overload, so you can deposit heavy metals or other metals in the liver, and that one of them is hemochromatosis, so that's iron overload of the liver. And then another very rare one is Wilson disease, which is deposition of copper in the liver. You can deposit and have buildup of other proteins, and one of those diseases is called alpha-1 antitrypsin deficiency, all right? So there's deposit-based chronic liver disease that can happen as well. So just some buckets to think about. So we're going to move on. So these are kind of the overarching chronic liver diseases. So let me ask, how does a person initially get diagnosed with a chronic liver disease? So I just want to warn you of how terrible my handwriting is, and so no one make comments, okay? Yes, what were you saying? Yes, oh, great. So diagnosis of CLD, okay, chronic liver disease. So one is elevated liver tests, right? So you mentioned liver enzymes. thoughts? Does anybody know what liver enzymes are? What are liver enzymes? Yeah, so someone mentioned AST, ALT, right? So the driver really is ALT, okay? AST is there as well, but AST is good for if you have a chronic muscle injury, AST goes up much higher. And if you develop cirrhosis of the liver, AST can be higher than ALT. And also alcoholism, AST usually is 2 times higher than ALT, okay? But here's the critical thing. These are the liver enzymes. And that's spot on. This is what really hones in on chronic liver injury going on. It's not one set. Typically the definition is you check it over a 6-month period, and if it's still elevated, then you have some chronic liver injury going on, okay? So what is considered an elevated ALT? One option is it's whatever the lab range tells me it is. And then someone says, wait a minute, the lab range keeps changing. So do you know how we come up with lab ranges? Does anybody have an idea? These are all things we assume. Yes? What was that? Did somebody say
I
something?
think you sample the population and look,
Yep.
and then find the means and statistics.
Exactly. So you sample a population, you get a nice bell-shaped curve, typically, if you sample enough, and then you take the extremes and, you know, the 2.5% on each side, and that is your cutoff, right? So it doesn't seem super scientific. The problem has been in chronic getting ALT elevations. When you take the general population, that is a mixture of people who have fatty liver disease, may have chronic Hep C, may have other causes of why their liver test, including taking a statin. It's okay, your statin will be up, your ALT will be up with a statin, but it really makes a problem with this here. So they actually did a study in Italy, this was about a decade ago, where they excluded everybody with known or suspected chronic liver disease and then did the map of what are the range. So any thoughts on what? Any guesses? ALT, all right. For males, less than 30. For females, less than 20. So it's not even a range, it's just below a number, all right? And you'll see when a patient with hepatitis C gets treated, you'll see their, especially in females, you'll see their ALT drop to like 18, 14, okay, if they don't have any other chronic liver diseases. So you'll see that. So lower the better, okay? So it's 30 and 20, all right? So liver enzymes is really a good way to kind of identify who has chronic liver disease. So I'm going to expand this a little bit. So what are the liver function tests? So LFTs. So what are those? Okay, so 2 things that your liver does, roughly. One is it clears things, and it synthesizes things. 2 rough things. So when your liver is ill and can't clear things, one of the things that can't clear is bilirubin. So what happens when you can't clear bilirubin? Your total bilirubin goes up, and guess what's the first thing you see in the person? They turn jaundice, right? There's your link right there. So when a patient says, I think my eyes are yellow, I'm yellow, I know I am, the first thing you do is you get blood tests, and if their bilirubin's normal, it's not from liver disease, all right? So that's a common thing. My eyes are yellow. Well, that looks more like it's muddy, not that it's really yellow, and you just check your total bilirubin. So that's clearance function. So synthetic function, so producing things, albumin, right? So albumin is a protein, and it's highly sensitive in terms of the liver produces it. So if your liver is ill and not functioning, albumin will go down. Another one that is dependent on protein production is clotting. So INR, right? So when your protein levels go down, you can't produce the proteins you need, your INR, which is one of the, is based on proteins and factors for coagulation, the INR will start going up, okay? So don't have to memorize it, right? So you know, it's liver clears things and produces things. And you can immediately look at the labs and go, oh my gosh, these are the markers of liver function. So I'm glad no one said AST, ALT is a part of liver function. It isn't. It just tells you if there's chronic injury going on. So this goes after the inflammation, and this goes after the function. Does that kind of make sense? Okay. Then there's another strange outlier that's become very popular and very sensitive and can be very specific for cirrhosis or advanced liver disease, and that's platelet count. And you go, well, how does the platelet count connect anything with cirrhosis? It doesn't tell you much about chronic liver injury, and it does give you an indirect look at liver function. But how it really, what it's telling you is when you develop cirrhosis, blood does not flow as well through the liver for many reasons. One is a structural reason. Scarred down tissue, the resistance in the liver is higher, so the blood can't go as easily through the liver. There's other compensatory mechanisms that your liver has as well, but that's one of the simple ones that your patients would understand. The blood has to go somewhere. So one of the places it goes to is to the splenic vein, and eventually what happens is you get splenomegaly because now the higher blood flow into the spleen engorges the spleen. And does anybody know one of the basic functions of the spleen? It's an immune organ, but what do you think one of the functions is? It's funny, we all talk about the spleen, but it's very hard to understand what the spleen is. What the spleen does is it actually clears away old cells. So it's a place where cells go to die and then get processed and taken away. So if you have a hyperactive spleen, what you start seeing is cell populations being inappropriately destroyed or chewed up or consumed, right? So one of the sensitive ones is platelets. So if you have a large spleen from this high pressure in the liver and you develop portal hypertension, we'll talk about that in a second, you engorge the spleen and you sequester platelets, so your platelet count goes down. So if you see a low platelet count in someone with chronic liver enzyme elevation, you gotta go, wait a minute, am I dealing with cirrhosis here? And do we need to do other studies to look at it, okay? You'll also see people with really massive spleens from cirrhosis. Their white count will be very low. They'll be anemic, and they'll also have a low platelet count. And I've had people just absolutely freak out, primary care providers and oncologists saying, white count is 1, we have to give them growth factor, we have to exclude infection, we have to put them on prophylactic antibiotics. And I'm like, no, they have cirrhosis, they have a big spleen, we know the reason why it's there, don't worry about it. So I've got patients who have white counts of 0.8, platelet counts of 10, they do fine. Okay, so you don't have to transfuse, because guess what, if you transfuse, where does all those platelets go? Right into the spleen and just get chewed up again, all right? Then you'll cause the spleen to become even more active, it'll start swelling up even more, and you start this horrible cycle, okay? Then you start developing antibodies to the blood products, and now you can't transfuse them again. So you will see that in severe liver disease, they can become pancytopenic, all right? But the first marker is a low platelet count. Anything under 150, it's a red flag, okay? So wonderful job. Liver enzymes is what points to chronic liver injury. Then you have the liver function, and this is a really good one. So I have this habit now, whenever I see somebody with chronic liver disease, I immediately look for where's the CBC. And my luck always has it, no one orders the CBC, or if they do, it's not with the platelet. And I'm just like, oh my God, this doesn't help me. So if I ever get a patient, this is one of the first things I look at, have chronic liver disease, right? So what's the mantra of what your patient is asking when they come in with chronic liver injury? What they want to know is what's causing it, right? And what can you do about it? So we talked about what's kind of the differential. And then the second question any human being would ask, I would ask is, how bad is it, right? So now we're going to shift from diagnosis, or what are the causes, to how bad is my liver, all right? These are two questions that every person with chronic liver disease wants to know, and we should be obligated we want to get to the bottom of that because that's the care that we want to give. Because if it's really bad, then we need to think about other things to worry about here, okay? So this is in the realm of cirrhosis. So when a patient is seen with chronic liver disease, you want to answer why is it elevated and how bad is it, meaning do they have cirrhosis? All right? So that's kind of part one. Anything, questions about part one? Part two is we're going to do a deeper dive into cirrhosis. Any questions? All right. Yes.
To you, just since we're going to move away from it, at the beginning you were talking about overweight and obesity towards fatty liver. So you had mentioned 20 pounds, if you lose 20 pounds in a year, that over that year you would start to see some improvements
Yep.
in regeneration. So in the pediatric population, because I work in a family practice and I've been working with kids on overweight and obesity, and sadly, so many of my kids that are overweight all have fatty liver.
Right.
And so I try to talk to the parents about it, but I mean, is it 20 pounds a year for a kid, or?
I would say the literature in the pediatric population is less robust, but I suspect it's roughly about the same. And your question is really getting at is, why are you so specific about how much weight? Because if you have too rapid of a weight loss, you actually have a very paradoxical reaction. You actually dump even more fat in the liver. So because, physiologically, as you have rapid weight loss, something happens and it actually shifts more fat into the liver. So the idea is you want to have not rapid weight loss, but slow, steady weight loss over a year. And it's incredible, at least in adult literature, that magic number of about 20 pounds, study after study. So there's been studies where they've used intervention arms or drugs as an intervention that were a negative study, but what they found in the study is in both groups, long as they lost weight, the fatty liver got better, okay? So it's roughly around 20 pounds. And again, I think in the pediatric literature it's much harder. And actually weight loss in the pediatric population also is much harder because many of these patients may also have metabolic syndrome, that's being overweight, diabetic, hypertensive, hyperlipidemic, and in those patients, weight loss is very difficult. And of course, there's a psychosocial environment input as well that makes it very hard. So they have also a genetic component, the ones who have early childhood obesity, so much harder. Any other questions? Great. So is this going okay for everybody here? All right, okay, I don't want to presume that. So we're going to switch now to cirrhosis. So diagnosis of cirrhosis, we just talked about labs, right? Labs are a way to diagnose cirrhosis. So we talked about labs, right? So check, we've covered that topic. What other ways can you diagnose cirrhosis? What's that? Biopsy, right, so histologic. And we already talked about that, and thank you for reminding me that we did already talk about that. Now, how great is this a safe thing to do? Not as safe as you'd like, sticking a needle in somebody's liver. It's overall safe, but conceptually it's a little frightening. Do you think it's inexpensive? No, it's about $5,000. And why it is, I'll tell you the physician fee is about 40 bucks. What it is the check-in, the short stay care, the IV they get put in, if they get pain meds, and then the recovery. So it's the short stay cost that makes it thousands of dollars because it's really hard to do it in a safe environment without having some short stay support, all right? So it's really expensive. Another way, so this is looking at scarring, is non-invasive markers or testing, right? And I looked at your syllabus. There is some slides on FibroScan, so that's a kind of a image technology that allows you to approximate how much fibrosis in the liver. There are blood tests. There are simple ones where you just calculate a ratio of AST and platelet count, and it gives you a good approximation. It's called the APRI score. There's also proprietary blood tests like FibroSpect, FibroSure that use proprietary proteins and other tested products, and they come up with a mathematical model and it gives you an approximation. So these are kind of histologic or fibrous-based ones. Other ways, so this is kind of lab, histologic, or fibrous-based. There's a couple of more. Yeah, so radiographic, right? So image-based. And as we had talked about, you know, the nodularity, you look for nodularity, right? So an ultrasound's great. So when an ultrasound is ordered, I always tell people, don't put down hepatitis C. The radiologist can't see the virus. What you're really asking for is, please evaluate for cirrhosis and signs of portal hypertension. Remember we had talked about the big spleen? That's from portal, so high pressures in the portal vein, portal hypertension. So that's what I write. I never write Hep C. What does that matter to a radiologist? What you want them to tell you is, radiographically, are there signs of advanced liver disease or end-stage liver disease, okay? So that's radiographic, laboratory, histologic, and one other one. Blood we have, labs. Exactly. Clinical. The old clinical, right? Now let me tell you, you can read about it, and I've got slides on it about looking for palmar erythema, spider angiomas, or little spots on your chest and on your back, testicular atrophy. There's all these things, gynecomastia, swollen breast. Yes, but they're not very sensitive, meaning a lot of times in people with cirrhosis you don't find them, and they aren't very specific. So for example, the spider angioma, those little spots you get, that's really, the thought is it's based on high estrogen levels. So who else can potentially have high estrogen levels? Many people in this room, potentially, right? So you would hate to do a physical exam on a patient who has no business having chronic liver disease cirrhosis and say, ma'am, you may have cirrhosis because I found these spots. That will start off a very terrible tirade of concern and backlash you don't want to get into, all right? And testicular atrophy in men, that occurs because of low testosterone state, all right? So again, remember the liver produces things, and it can produce not only proteins but hormones, all right? So those are not, those are physical exam findings you can always look for, but since they aren't very sensitive or specific, it's not going to give you the definitive. It can make you suspicious, but it's not going to be as definitive. So what are some of the clinical things that you would look for? Large spleen, right. So exactly, large spleen. Yep, so you can have a palpable margin, although I feel that often or I don't feel that, I don't know. But yep, that's definitely one of the things you can look at. Some really other obvious ones. What's that? Jaundice, and someone mentioned ascites, right? So jaundice. You can see the beautiful link with many of these with the labs, the concept of portal hypertension. So remember the links, right? You don't have to memorize any of it. Just remember the link. Scarred down liver causes back pressure because obviously it's scarred down, high resistance. The blood's got to go somewhere. And then you can start the cascade of what's going to happen. Well, the liver's not functioning well. Well, what can happen? Bilirubin's going to rise. It's not synthesizing things, so your albumin's going to go down. So jaundice, ascites, right? I think somebody mentioned ascites. If not, I just hallucinated that, but that's okay. So ascites. So ascites is fluid in the abdomen. So how good is a physical exam in identifying ascites? So there's, believe it or not, there actually has been a study on this, taken liver experts. I just want to let you know, if anyone says that they're an expert or they're a thought leader, just slowly walk away. This way. Don't turn around and get something in the back here, but just slowly walk away. But it just gets to show you that even among liver experts, what they found was they had them examine patients with potential chronic liver disease and potentially cirrhosis, And they were correct 50% of the time. It's flipping a coin. So sometimes you'll see somebody with a protuberant belly and you're convinced it's ascites, but when you tap it, it's kind of hollow sounding. That's gas in bowels and not actually fluid. But if you tap and it's really dull, especially if you can find where it's hollow then dull, then you're at a better chance that this is ascites. So you can actually tap it out and see, all right? What I just do if I suspect it, I get an ultrasound. Because even with tapping it out, maybe I've increased my chances to 60% being correct. Wow, that's not great. You're making a really important diagnosis that may require medications. You better get an accurate way of diagnosing it, okay? Any other physical exam findings or muscle wasting? Thank you. So muscle wasting is something that's now being heavily studied. What really causes problems is defining what's truly from the liver and what's truly from just malnutrition and or a combination of both, right? Because just want to let you know, when you're 9 months pregnant with fluid, you're not going to be very hungry. So this combination is always hard to kind of tease out what is causing it. At the end of the day, you can do something for malnutrition, right? Tell them to eat more. So does anybody have any cocktails, or not alcohol cocktails, but just, shouldn't have said it that way, but what dietary measures you may want to give to a patient with cirrhosis? Kale smoothies, okay. So I keep it very simple, because getting into very complex dietary regimens, at the end of the day, they're either very expensive or a patient can't keep up with it. So I keep it very simple. One is a low sodium diet, and we'll get to that with ascites in a second. And the other is, if you don't feel like you can have 3 square meals a day and 2 snacks, then you have to supplement it. And what I mean by 3 square meals a day is get a pattern from your patient. Ask them, so when you have lunch, what is it? To a patient who's ill, just taking 3 bites, I've had lunch. That is not lunch, all right? So really have to understand what is the amount that they're having at each of these meals. And many times, especially if they have tense ascites and they have muscle wasting, their PO intake is horrible. So what I simply just do is this. I tell them to, especially if they're struggling overall, I tell them to drink 5 nutritional shakes. And you know which ones I use? Just use Carnation Instant Breakfast Drink. Because it's inexpensive. It comes in a variety pack. You can mix that powder with anything. You can use ice cream and put it in a blender. You can do it with fruit. You can do it with water. You can do it with milk. More the better, all right? And I'll tell you, most of my patients have said things like Ensure, Sustacal. They taste terrible, and they're really expensive. So you can tell them, yeah, buy some Ensure. Most patients will come back and they haven't bought it. They go and see how much it costs. For a month's supply, they're done. All right, so I tend to use Carnation Instant Breakfast Drink, and what I say is every meal that you cannot really do a good job with, have the drink instead. So some of my patients who are in dire distress in terms of their nutrition, just 5 of those drinks. Just line them up and finish them by the end of the day. And as their nutrition improves and I control the ascites, you can start replacing a drink with a meal. And when I describe this to our transplant nutritionist, because these patients pre-transplant are really ill, she goes, oh my God, I never thought of that. And she now does that routinely with patients as well, because it's really just getting nutrition. There's very little science behind it. It's just getting calories and well-rounded calories. A kale smoothie is probably good, but a lot of those smoothies is just sugar and very little kale. So the things about the Carnation Instant Breakfast Drink, they have most of the basic nutrients. And then as they start eating regular food, you want them to start switching to regular food that's well-rounded and well-balanced, all right? No science. The only food restriction is a low-sodium diet, which we'll get to in a second. So these are some of the things. The other things you also want to think about is so ascites, muscle wasting, encephalopathy, right? We'll talk about that in a second. How about variceal bleeding? 5 years ago, I yorked up blood, and a doctor put a scope down and found swollen veins, and they had to do something with it. Okay? So these are some of the, not maybe physical exam, but also clinical findings, right? So you can get it from their history. I'm going to emphasize something here. Let's put down variceal hemorrhage. If you have these, or this, or labs that point to cirrhosis, you don't need to do this, just in case. And I see still with my gastroenterology colleagues, some have all this other stuff, big old belly, they're yellow, and they do a liver biopsy just to confirm cirrhosis. That is very dangerous. No reason to do it. So any one of these, if it's fulfilled, they have cirrhosis. You don't need to do a biopsy. And why I know that's true? If you look at studies on cirrhosis, the criteria is either histologic, laboratory, or image or clinic-based diagnosis. You don't need all of them. Just need one. So if it's good enough for the NIH, it's good enough for us. Okay? Yes?
Aren't most of those late signs of decomp?
Yeah, well, that's cirrhosis. Yeah, that's exactly right. These are late signs. Where you can potentially catch it early, thank you, is maybe the non-invasive testing that catches the cirrhosis early. But almost all of these signs here, and the image can as well, once you get into this is late. So you are my perfect segue into the next phase of cirrhosis. Yes?
This is sort of an aside, but what percentage of Hep C, chronic Hep C cases result in cirrhosis?
Great question. So on average, 20% progress to cirrhosis. So this is the big dilemma, right? Is that unlike, for example, in HIV, where if untreated, overwhelming, almost all of them are going to progress to immune deficiency and death. In Hep C, what's complicated is the majority will not. But every one of them will always be at risk. That's the problem, right? And sometimes it's very hard to obviously define who's going to progress or not. As I tell patients all the time, what is your chance of getting cirrhosis from your Hep C? It's not 20% because that's not 20% of a person, right? It's either, if you think about it, in the individual person, that's either going to happen 0% of the time or 100% of the time, right? In the individual person, it's either going to happen or not. Yes, no. So when you're talking to a patient, remember, don't tell them, you know, when you say you have a 20% chance of cirrhosis, you do have to point out that in you as an individual, you know, I don't know if you're going to be in the 20% bucket that's going to develop cirrhosis or in the 80% bucket that it's not. Because for an individual person, it's either going to happen or not. So that's the subtlety, right? We always talk about probability, but probability is hard when you're trying to counsel an individual patient. Because in their mind, like I would, well, is it going to happen to me? You know, that's what I want to know. So we have to be careful about that, yes.
Does length of infection have anything to do with
It does.
cirrhosis?
Length of infection. So if you've had it for 20 to 30 years, you have a higher chance of having hepatitis, cirrhosis due to hepatitis C. Also, other co-modifiers. If you're overweight and have fatty liver, if you drink or have other chronic liver diseases as well. So there's many co-modifiers that actually can cause progression of onto cirrhosis. And those variables change over time, right? Someone could drink for a bit, stop drinking, then go back to drinking, next thing you know, they have cirrhosis. So that's definitely an issue. Any other questions as we keep going deeper dive into cirrhosis? Because what was now pointed out by the clinical stuff is, wait a minute, by the time you have jaundice, by the time you have ascites, isn't that really far along? So here is, as I'd mentioned earlier, is the new concept of how to look at cirrhosis. So you start off with chronic liver disease, This is your patient has chronic liver disease. Over time, they develop cirrhosis, and from cirrhosis, you can either stay compensated, cirrhosis, or decompensated. Cirrhosis. This is it. This is what 100+ years of research in cirrhosis we've come to, which is what I love, because you have to always bring back the science back to practical conceptual terms that you can actually use to manage people. So you get chronic liver disease, you develop cirrhosis. We talked about what things can get you to cirrhosis, right? You get an image study, oh my God, you got a nodular appearing liver and a big spleen. Okay, they don't complain of anything. So that would be compensated cirrhosis. So this is where patients get really confused, right? My doctor told me I have cirrhosis. I'm going to die, right? But I feel great. I don't understand. Well, where they are, they're still compensated. Their liver is functioning just fine. Patients will always ask, well, when you tell me I have cirrhosis, how bad is my liver? You know, is it, someone told me or I read that 80% of it is destroyed. There's no way for us to know. But what you can't tell patients is, if they're compensated, is you have just enough that your liver is going to function fine. All right? So then I give them an analogy, and I think it helps patients. I think, and no one's come back and said, oh my God, this has changed my view of cirrhosis, but this is how I try to explain to my patient is. So I does not have cirrhosis. I don't. So last time I checked, I didn't. And if I was with somebody else in a car driving who happened to have compensated cirrhosis, meaning they're perfectly fine, they're asymptomatic, and we were in a terrible car accident, horrible car accident, and both of us had massive injuries, internal injuries, trauma from the seat belt across the liver. Both of us are in the ICU. What you would see is all of our liver numbers initially would look identical. Our liver enzymes, because remember, it's acute liver injury, we're not going to talk about that outside of the scope of this talk. Your liver enzymes are in the thousands. You actually, bilirubin could be 40 because you have acute injury and everything just shuts down. Your albumin could be 1. So both of us have identical labs. I will recover. My friend who has compensated cirrhosis has a good chance that he or she will not recover. And what that concept is of reserve, your hepatic reserve. So once you have cirrhosis, although it's compensated, you have very little reserve to injure, to take on further injury. So you have this incredible reserve because it's a very central organ. And a lot of things happens through the liver, right? That's why alcoholics can be alcoholics, massive alcoholics, for decades and never have a problem because of the reserve. And everybody reacts differently based on what reserve is left. But this person has very little reserve. So you know what I tell my patient is? And they laugh at this. I doubt they do this. Every morning, if you have compensated cirrhosis, you wake up and say, what can I do to help my liver? And what can I not do to piss off my liver? Okay? There are things we can do that can upset the liver. And once you upset it and cause injury, you can then switch to decompensated cirrhosis. So what events define decompensated cirrhosis? We've talked about a few already. No. What clinical events? Thank you. Sorry about that. It wasn't clear. Ascites. Ascites is an event that is now taking somebody who has compensated cirrhosis to decompensated. Somebody with new onset ascites, their survival goes from a 5-year average of about 80%, it drops all the way down to about 20% with your first event of ascites. So this is huge. So this is okay. You can go on like this for a very long time. The moment you develop ascites, you're in trouble. You've now moved into the decompensated range. What other events? Esophageal varices. So I'm going to variceal hemorrhage. So now what you're showing is, so ascites is caused by liver dysfunction. All right? You're developing less and less protein, and your oncotic pressure across your blood vessels is kind of going off kilter. So now most of that fluid is going across the cells, the vessels, and into abdominal cavities and other cavities. That's why you can develop anasarca and lower extremity edema, because that's what's happening here. There's also a component of portal hypertension that's causing it as well, but I try to keep it simple, look at it as a liver dysfunction is causing it, okay? So variceal hemorrhage is just, okay. Variceal hemorrhage is related to portal hypertension, all right? High pressures, we had talked about, scarred down liver, the blood can't flow as well, and it backs up, and then you develop high pressures, and those pressures that happen in the esophagus, the esophageal veins start swelling up, and they can rupture and bleed, okay? Any other things? Encephalopathy, perfect. Any one of these events, by the way, you're now decompensated. Now you have to start thinking about, does this person need a liver transplant? Is he a good candidate, he or she a good candidate for a liver transplant? Maybe needs to see a specialist, okay? Encephalopathy is a combination of liver dysfunction and also portal hypertension. And there's controversy in literature. I've got a slide that says it's all portal hypertension, another slide that says it's all liver dysfunction. But the two competing things with hepatic encephalopathy is, one of the things that your liver does is I tell patients, it's not a technical term, but it kind of cleans the blood, right? And when it's ill, it can't effectively clean the blood, so that's liver dysfunction. But what also happens is, when you have high pressures in the portal vein, so that's the vein that feeds, the major vessel that feeds the liver, the blood backs up, it doesn't flow as well, and then it goes to other places. Well, if it's going to other places, the blood isn't clean. So it has to go around the whole body circuit again, and maybe after 1 or 2 more passes, it'll finally get filtered through the liver. So while it is not clean, what happens is levels of neurotoxins go up. So what is one of the, and you notice I didn't use the word toxin. Oh, it's like the word organic. I can't stand, because I don't know what toxins mean, right? Neurotoxins, I know, are scientific molecules that cross the blood-brain barrier and can lead to confusion. So neurotoxins can build up that your liver has not been able to clean. What is a common neurotoxin that is elevated in hepatic encephalopathy? Ammonia. And we all say this with great confidence. So if you look at the literature, people with no evidence, clinical evidence of hepatic encephalopathy, a third will have elevated ammonia level. If you take people with overt hepatic, I mean, they're just completely confused and clearly from hepatic encephalopathy, a third will have normal ammonia level. So it is all over the place. It really is a terrible marker for hepatic encephalopathy. I've had colleagues of mine call me up and say, Atif, I've got a patient here who's got an ammonia level of 300. I don't know what to do. I said, well, how does the patient? Oh, the patient's fine. I said, okay. Are you treating the lab number or are you treating the patient? Oh, I guess I'm treating the patient. So I don't even check an ammonia level. Sorry about this. So I think the best thing to do is when you have somebody that you think about hepatic encephalopathy, you look at it in the terms of clinically how are they, all right? So hepatic encephalopathy, how you diagnose it is the spectrum of confusion could be as minor as reversal of sleep-wake cycle. So one of the first things I ask my patients with cirrhosis is, how do you sleep at night? And if they or their spouse or their loved one says, oh my God, they are just tossing and turning, they're getting up in the middle of the night, and then during the day they're just dozing. That's hepatic encephalopathy. That's one of the earliest signs. How do you balance your checkbook? Oh, I've stopped doing that a month ago. I can't add numbers anymore. That's hepatic encephalopathy. And the spectrum goes all the way to a coma, including focal signs like Babinski and having seizure activity. Well, those patients are in the hospital, right? Many of those may have a normal ammonia level because that's only one of many neurotoxins that could be elevated that we just don't test for, all right? So the spectrum is wide. So in clinic, just asking about reversal of sleep-wake cycle and can they add things anymore. Should they be driving? If you found that they have hepatic encephalopathy, the answer is no. Even when they're on treatment, you'll get in second lecture, I think the second lecture, you're going to get some on how to treat hepatic encephalopathy. When we have time at the end, if anyone wants to ask me, I'm happy to talk about it, but you'll get something on discussion around hepatic encephalopathy. But you have to pretty much clear the toxins one way or the other. And one way is you decontaminate the bacteria in the GI tract that cause it, and another is you just poop it out. There are two ways to do it. So that's hepatic encephalopathy. There's a fourth one that's considered one of the sentinel signs of decompensated cirrhosis, and that's liver cancer. So that is considered a form of decompensation, okay? So once they have this, that's when things are going to start going south, all right? So that essentially is the natural history that you have to remember. So we teased out hepatic encephalopathy. Let's tease out ascites for a second here, okay? So I mentioned to you the low sodium diet. That's the diet they want to be on. And everything else should be a high quality, well-balanced nutritional regimen is what they need, okay? There's no liver diet. There is no liver supplement. None of those things have ever been shown yet to make a difference. So keeping it very basic is really, really important. When I have somebody with ascites, I suggest that they're on a low sodium diet. Once they, without ascites, if they develop ascites, it's a low sodium diet that I'm very scripted about. I usually say less than 1,500 milligrams of sodium. If you look at the literature, it says less than 2 grams of sodium. And you know why I say 1,500? Because of human nature. And I'm included in that human nature. You put a threshold of 2 grams, the patient will do 2,500 milligrams, right? 2.5. If you say 1,500, they'll probably be right around 2 grams or less, all right? So I always kind of cut it down. There's actually been studies done in liver research units where they've actually reduced sodium intake to under 250 milligrams, and it's highly effective in controlling ascites. Just most people can't live on less than 250 milligrams of sodium. So I'm saying this is that the first step with ascites is a low sodium diet. Yes?
Let's talk a little bit about sodium in the blood relation to oral.
Perfect, yes, great. So Chris is bringing up something that I was going to mention to you is, so does anybody have an idea of the relationship of salt you take in and your serum sodium? It's a very poor relationship, horribly poor. You know that we are majority of we are water, right? So so water is intimately related to sodium. So the mechanisms in our body to address sodium homeostasis. So these are the kidneys. So if a kidney doctor is up there, they'd start blushing and start talking about sodium homeostasis because it's unbelievably complex, but it is one of the most wondrous things that the human body does. It's incredible. It's complex, it's elegant, it's beautiful. But a simple old blood test does not define sodium levels throughout the body or sodium hemostasis. And this is where one of the faults comes in. Someone with cirrhosis will have a slightly low serum sodium, blood sodium, and the advice given is take some salt tabs. That'll get the sodium up. It may get it up a little bit, but what you're actually going to do is make them retain water. So your ascites, you know, as I mentioned, a strict low sodium diet treats ascites. In none of what I've said did I mention fluid restriction. Didn't. Because fluid restriction without salt restriction is nothing. Because it's not the water you take in, it's the salt you take in that causes fluid retention. Remember, sodium homeostasis is a very complex process. So when you're on water pills, diuretics, it will artificially make you lose sodium. So then some providers will see a low sodium, serum sodium, they'll give them diuretics and give them salt tabs. Salt tabs will make you retain sodium, and then you're giving diuretics that is going to get rid of the water. That's crazy thinking, right? You're just feeding the retention and treating it with a diuretic. So first salt restriction, then you use diuretics, and only when your serum sodium is like less than 125, that's when you consider fluid restriction. But if you're dealing with somebody who has sodium less than 125 and they have ascites on diuretics, that is someone that should be going to see a hepatologist, because that person is likely going to need a liver transplant or will not be living very long. That is a very, very bad sign in somebody with cirrhosis who has a low sodium. Really bad sign. So thank you, Karista. So remember that, so it's the salt intake has very little effect on your serum sodium, so you don't need to look at that. Diuretics will cause your serum sodium level to go down because you're wasting sodium. So ascites, at your next talk, they'll talk about the diuretic dosing and all that stuff. I'm not going to get into that, but it's spironolactone and furosemide is what you use. Encephalopathy we talked about. Variceal hemorrhage, that's going to be taken care of by an endoscopist. I think in your handouts you do have some things about variceal hemorrhage. Not much you have to know about. It's going to be taken care of endoscopically, and they do use beta blockers, but I think it's really beyond the scope of what we're going to talk about. By the way, how do you diagnose varices? Endoscopy. How do you diagnose variceal hemorrhage? Endoscopy, right? So sometimes what I'll see is patients are told, well, I've got varices. And I said, well, did they do an endoscopy? No, I vomited up a little bit of blood, and my doctor said it was varices. And you have to actually look, because 50% of the time, a source of your upper GI bleeding is not from varices in the cirrhotic patients. It's ulcers, it's esophagitis, so you have to diagnose it with an upper endoscopy, okay? Liver cancer, and this goes back to some of the long-term management of cirrhosis. How do you diagnose, liver cancer? Thoughts? Yep, ultrasound or MRI. Ultrasound is usually the best first step. How about alpha-fetoprotein, the tumor marker? Not a good marker. It's terrible. About a third of people who have elevated alpha-fetoprotein have no tumor. A third who actually have tumor have a normal alpha-fetoprotein. So not great. So if you look at the most guidelines now, it's image-based. Ultrasound is a great first screening tool. And on average, you do a scan every 6 months. And the reason is it's the half-life or the doubling of cancer is about 6 months, all right? So that's going to be really important that you do it every 6 months, not once a year. You don't have to do it every month. It's every 6 months. This is way too advanced to talk about treatment for liver cancer. Once you image-based, if you, on an ultrasound, you see a spot in the liver, the second thing you do is you get a dynamic imaging study. That includes an MRI with or without contrast, or CT scan with or without contrast. If it then looks like cancer, you don't need a biopsy, you refer to a specialist, okay? Because that's something you definitely don't want in a primary care setting to take care of. That has to be reviewed in a multidisciplinary approach, because sometimes you can resect the cancer, sometimes you can ablate the cancer, sometimes you can radiate the cancer, and then some patients liver transplants, an appropriate modality as well. Way too complex, and in our liver cancer group, we argue all the time about what's the best one, because there's many times more than one option for the patient. So decompensation, once a patient decompensates, on average, 5-year survival is about 10% or less. So you automatically have to start thinking about referral, or what else do you have to go? Yes?
I was just going to ask real quick for pancytopenia that you talked about. If that's not a sign of decompensation, that's just a sign of chronic.
Right, yeah. Yep, exactly. Great. They're still compensated. They have a big spleen, but they're still compensated. But with a very low platelet count, you know that they've got probably high pressures, portal hypertension, and do not be surprised soon that they're going to have these here. That's why when you have cirrhosis, you screen for esophageal varices. So once you've diagnosed cirrhosis, you do an endoscopy to look for varices. If you don't see them, you do a scope every 3 years. If you do see small ones, you do it every year to see if they're going to grow. If they're large, you can actually put rubber bands on the varices, or you can put them on a beta blocker. Okay? Again, beyond the scope here, but I think some of your notes have that here. It's almost like what you do with screening colonoscopy, right? If you have a normal colon, you do it in 10 years. If you have small polyps, you do it in 5 years. If you have large ones, you do it in 3 years. It's that same concept, okay? Good, so I'm gonna end here. So we've, and again, like I said, the next lecture is gonna kind of go through the meds on some of these here, and it'll be kind of a repetitive thing for here, but I wanted you to get the conceptual idea. Tylenol, I didn't wanna forget about talking, we talked about statins, Tylenol. So between Tylenol and NSAIDs, which is the most dangerous for the liver? What's that? Tylenol is the most dangerous for the liver. Okay, so I'll ask another question. Somebody with cirrhosis, what organ do you worry about the most? It's a totally trick question. What was the answer? Kidneys. How did you guys know that? That is exactly correct. When you have somebody with cirrhosis, you obsess about the kidneys. That is your new obsession, okay? You will stare at the creatinine, you will assess patient's volume status, and you will not allow them to take meds that can cause kidney injury. So I will ask you the question again, which is most dangerous for your liver if you have cirrhosis, Tylenol or NSAIDs? NSAIDs. Because once you develop acute kidney injury, and if you go on to develop hepatorenal, your chance of death is close to 100%. Okay? So NSAIDs are the bane to somebody with cirrhosis, because they not only can cause ulcers, GI toxicity, but it's the kidneys. The nephrotoxicity is very, very high in patients with cirrhosis. There's this really incredible physiologic link with the liver and the kidneys. So when the liver gets sick, the kidneys are at huge risk. It's because what you get is when you have cirrhosis, you develop compensatory renal vascular vasoconstriction. So the vessels that feed the liver, that supply the liver blood, constrict as a response to the liver developing cirrhosis. And that puts it at risk, right? So now you add nephrotoxic drugs, they're going to go into kidney failure. Tylenol is safe, but what is considered safe, right? Should they be taking a bottle a day? No. So on average, if you're under 2 grams of Tylenol a day and you take it once in a while, it's safe. Okay, so I tell my patients, take 4 extra strength Tylenol tablets a day at most, and maybe a few times a week. If they have chronic pain, you have to first address what's the pain from, try to treat the underlying problem, and if that can't be done, I hate to say it, pure narcotics is probably the best way to go. But you can try, if it's back pain, you can try a TENS unit, you can try topical things, you can try topical NSAID-like products, because topical is not going to cause a problem, but ultimately you end up with a pure narcotic if there are ongoing, unrelenting, let's say back pain from multiple herniated discs and things like that. So that's Tylenol. Any other questions? Because we're ready to wrap it up really soon. Yes?
Quick one. You mentioned beta blockers.
Yes.
So patient that is compensated, has compensated cirrhosis,
Mm-hmm.
would you start patient on beta blockers?
Beta blocker. Great question. So the question is around the timing of when to use a beta blocker. So it's really for people who have cirrhosis, because a certain percentage of patients will develop varices, right? So there's been studies looking at is, well, maybe we can just put them on a beta blocker when they just have been diagnosed with cirrhosis, even before they develop variceal hemorrhage. Well, that study unfortunately was a negative study, meaning that it had no impact on development of varices. And once they develop small varices, there's been studies saying that, well, what if we put them on beta blocker when they have small varices, maybe we can reduce the progression onto large varices. That had mixed results. People who had more advanced liver disease, they tended to benefit from being put on beta blockers when they had small varices, but it was very complicated and conflicting results. Some studies said yes, other studies said no. Once they develop large varices, that's where the best evidence. When you put them on a beta blocker, you reduce the risk of bleeding by 50%. Does anybody know some of the side effects of beta blocker? What's that? Right, so slow heart rate, fatigue, hypotension, lower extremity edema, and erectile dysfunction. So when you're on a beta blocker, you have to be on it long term. You actually have to get the heart rate below 60 beats per minute for it to work. So you can't put them on a homeopathic dose of beta blocker and say, okay, I'm done. You actually have to up titrate it so your heart rate is ideally closer to 50 beats per minute. Usually by the time you get to that point, some of the symptoms start coming up. And we now know that if you are hypotensive at baseline, let's say you're around systolic blood pressure is around 90, and you have tense ascites or profound ascites, adding beta blocker actually increases your risk of death. So now there's this window period we talk about, again, beautifully conceived. I think it's so great for hepatologists and for gastroenterologists who deal with liver disease, where there's that ideal window period of where you want to use a beta blocker. Outside of the window period is once you've developed massive ascites and you're hypotensive, because you will increase your risk of death. So I tend to just do band ligation. I don't have to worry about then, oh my God, my patient hasn't seen me for a year because they just haven't shown up. Now they show up with tense ascites, hypotensive, and I have them on a beta blocker. Ugh, that never looks good. But, although they haven't seen me. Yes?
I have a diet question.
Yes.
Some physicians I've seen recommend high protein diets, and others have
Others
discouraged
Thank you.
because of ammonia.
I had a mental note to please talk about that, and I forgot, so thank you very much. Great question. I really appreciate it. So the $1 million question is around protein, okay? So a lot of people will say, when they see their cirrhotic patient, now they have low albumin, right? Because they're not producing protein, ramp up on your protein, all right? And or if they develop encephalopathy, they'll say, hey, reduce the protein because high protein load does cause encephalopathy. So you have to be careful on both. So when you reduce protein in a cirrhotic patient, you're actually doing them a lot of harm, because now they'll become protein malnourished. Remember, their liver is injured. It is trying to regenerate. It actually requires more calories and more energy to function and to survive. So when you reduce the protein in their diet, their protein malnourished will go up, their albumin will go down, and their ascites will become more of a problem. So you don't protein restrict somebody even if they have encephalopathy, unless they have refractory encephalopathy. And I challenge you to find many of those. There aren't many of those. If you, so you're gonna make sure you don't protein restrict them in that setting, but you tell them also don't protein load. So don't have a 32-ounce steak in one sitting, or have the triple Big Mac burger or something like that, because that huge protein load will tip them over. So even-handed. Now, there's no real reason to up protein-only diet, protein-rich in somebody with cirrhosis, because a lot of their low albumin is a functional issue. It's adding more protein is likely not going to help it out. So what I tell them is don't protein load, because one day they may develop hepatic encephalopathy just because they're progressing and now you've been loading them with protein. I just tell them to have an even, average, well-balanced protein diet. And that typically, if you look at the literature, is fine. The problem is most patients with cirrhosis can't keep up with a good diet. So if you work on a good, well-rounded diet, you will not have to address the protein load or reduction in protein. But I would not protein restrict. We used to do that 5-10 years ago. Studies started showing, oh my God, we're causing more harm than good. And that came out of the nutritional field. Thank you for that. Any other questions? Yes.
One quick question. Post-HCV treatment and SVR, what is the regenerative capacity of the liver to have more compensatory?
Right. So I didn't mention this, but that's a wonderful question. So remember we had talked about chronic liver disease leading to cirrhosis, right? And one of the things you want to do is identify chronic liver disease and treat it if you can, right? So the question really is asking is this. So I've got somebody who has chronic liver disease, let's say from Hep C. They happen to have cirrhosis and have Hep C. So should I bother treating the Hep C or not, or treating the underlying, because now they already have cirrhosis? And the answer is that any ongoing damage you want to stop, because then you may slow down or reduce the chance of it going to decompensated cirrhosis, and it'll stay compensated. But then a step further, once you reach cirrhosis, if you treat the underlying cause, can you reverse cirrhosis? So that's a question. So the mantra used to be about, 5-10 years ago, once you develop cirrhosis, got cirrhosis. You're treating the underlying chronic liver disease so you don't cause progression, but it'll always be cirrhosis. Believe it or not, though, however, for the last 20 years plus, we've known that that was a wrong statement, at least in people with cirrhosis due to autoimmune hepatitis and cirrhosis due to hemochromatosis. Remember, hemochromatosis was the iron overload. Autoimmune hepatitis is autoimmune attack of the hepatocytes themselves, the liver cells. Because in that field, we've had patients, and there's been studies, where on initial biopsy before their treatment, phlebotomy for hemochromatosis and steroids or immunosuppression for autoimmune hepatitis, biopsy would show cirrhosis, clear cut. They'd get treated and they would get re-biopsied, and a good percentage of those patients would not have cirrhosis anymore. So we knew that that was the case. We now know in hepatitis B, long-term treatment with Hep B meds, about 70% will reverse their cirrhosis. In Hep C, we thought maybe it could, but because we used to use interferon, and patients, when they were at cirrhosis, the cure rates were much lower in cirrhotic, or it was dangerous using cirrhosis, we never treated them. So we didn't know the real literature. Now what we're finding with the new all-oral agents, that even if you develop cirrhosis, you can reduce some of the manifestations. Some include portal hypertension. So 1 year out, many of those patients will have reduction in their portal pressure, and some actually reverse their fibrosis. The thinking is that there is a point of where you have cirrhosis beyond which there is no reversibility. So obviously, if that's the case, once you develop decompensated, you're never going to reverse the cirrhosis. you'll potentially compensate, but you won't reverse the cirrhosis, because that's really advanced cirrhosis, right? But what if you caught the cirrhosis just on a liver biopsy? Everything else looked perfect. There's a good chance when you clear the Hep C, some of it will resolve. So it's the timing. So there is reversibility. Your question is how many? It's unknown now. But those studies are now going to be done. And in our practice, when someone has cirrhosis and we clear the virus, about a year or two later, we're repeating a fibroscan. And if we see the then we'll see if the cirrhosis is gone. Because now we have non-invasive ways. I mean, doing another liver biopsy would be, I don't think would be justifiable. But a fibroscan would be. It's a great question. Any others?
So you talked about the weight loss. Are you saying, wouldn't that also drive it back?
It could. But most of the studies have showed the reversal of the fat. Studies have not gotten to the point yet to show that you reversal of the cirrhosis or not. But remember, the body responds to things the same way, right? So your point is, wouldn't you also see it in fatty liver? And the answer is probably. Just because the studies haven't been done, it doesn't mean the same pattern of injury and recovery wouldn't be the same, no matter what the chronic liver disease is. That's the beauty of, if I look at it as chronic liver disease, the patterns are consistent and you know where you need to work on the disease state to help improve or reverse things. Anything else? All right, so was this helpful, I hope? Perfect, all right, great. Well, thank you very much.